Here we go. So I think I stand between you and a break. Just bear with me for just a little bit. It's also a pleasure to be talking with you today. I have the privilege of representing the Society of Pediatric Psychology and the Society of Child and Family Policy and Practice on the forum, but today I'm actually wearing a slightly different hat. For many years in my career, I actually was fully co-located in the hematology oncology department, working with kids with sickle cell disease and cancer, and also became director of training in psychology, so also was simultaneously working in behavioral health and training psychology students and interns and postdocs. So I'm wearing a slightly different hat than I usually wear at the forum, but it's a privilege to be revisiting some of this. I want to present to you on something that our Table 4 has been really focused on today, and that is children with chronic illness and disability. So if we loosely define chronic illness, as many as 15% of children are affected, and prevalence appears to be rising. These are just some of the most common examples of chronic medical conditions. I want to remind us all, we've heard about this a little bit before in prior workshops, and we heard about it this morning from our opening keynote panel, which was amazing. The chronic illness and medical treatments pose repeated and sometimes traumatic stress. We've heard about medical traumatic stress before. They also pose interruptions to healthy development. Some conditions and or treatments are associated also with cognitive impairments, and we're crossing over here a little bit between behavioral health and cognitive functioning, because many of these cognitive impairments are in the area of executive functioning and self-regulation. Psychological distress can and does impact health. And there are very rich opportunities here for promoting behavioral health and preventing conditions. So there's basically a continuum of interventions working with chronically ill children and families. For all children and families, there's education. We heard about that this morning. Environmental intervention, and one of the examples here is, when we opened our bone marrow transplant unit at Children's National Health System when I was there, we had all the children had a whiteboard in their room, and we put them on a daily schedule to more mimic what their lives might be like outside of the hospital. Screening, and we've heard about that already today too, screening for both developmental issues and behavioral health conditions, and parent support. So that's something that all families facing chronic illness should receive. For children who are at particular risk, we should be offering, and we do offer, training and coping strategies. We heard about that today, especially for pain, cognitive testing and school consultations. Assistance with medical procedures, that's where a lot of the trauma comes from. So assistance in helping kids with medical procedures and adherence to medication regimens. Now that's where some of the health comes from. That's where some of the healthy outcomes come from, are adhering to medication regimens. And then lastly on this continuum, for children with identified problems, there's diagnosis, there's psychological and pharmacological interventions. So just to look a little bit at the training landscape, and I'm coming from the perspective of a pediatric psychologist. There's an estimated 65 internship programs in pediatric psychology in the United States, all of which have some level of interdisciplinary team training with chronically ill children and their families. That's where pediatric psychology was born. There are also a number of postdoctoral fellowships that offer specialization with these children and families. There's basically two primary models for training. One of them is consultation liaison, with psychology and psychiatry side by side. One example there is Mattel Children's Hospital in UCLA. Or co-location, and that is having a psychology trainee immersed in a medical department, in a medical specialty department. And two examples here are Children's National Health System and Nationwide. I admit I'm going to focus a little bit of my talk today on co-location because that's the model I'm most familiar with. But the consultation liaison model was probably the first model and still exists in many major medical centers. So here's some of the other healthcare disciplines that are commonly training alongside co-located psychologists. That's child life specialists, medical specialty fellows, nurses and nurse practitioners, nutritionists, pediatric residents, physical therapists, and social workers. Now, I don't want you to be intimidated by all of this text, but these are some of the knowledge competencies that have been proposed for pediatric psychologists, and I think they apply across all of the disciplines I just mentioned, right? This is what we're talking about in terms of training in behavioral health. And I'm speaking specifically to training in behavioral health as it involves children and families with chronic illness. So if you could just look at the bolded text here, we're talking about normative, adaptive, and maladaptive development, basically, okay? A knowledge of biological, cognitive, social, affective, and et cetera, lifespan developmental influences on children's health and illness. Pediatric acute and chronic illness, injury conditions, and medical management. The role and effect of families on children's health and of health, illness, and medical management on family functioning. And then lastly, let's just skim down here, the roles of other disciplines in health service delivery systems and the transition of pediatric patients to adulthood and adult-oriented healthcare. We heard about that this morning too. As refers to the future workforce, this important publication on knowledge competencies by Tanya Palermo and a task force in pediatric psychology noted, we'll also need a new level of integration, communication, and shared decision-making within and outside of a medical setting, so crossing sectors, understanding interprofessional teams and team approaches to both maintenance of health and prevention of disease. So let's think just for a minute, what are the mechanisms for training? How do we train across disciplines with chronically ill children and their families? Well, first of all, there are administrative meetings, and one of the most important ways of co-locating different disciplines together and being a truly functioning team is to share administrative responsibilities for a department. That's everything from hiring to evaluations and business issues. Clinical rounds. Often these are interdisciplinary with co-located psychologists. Psychosocial or behavioral rounds, and that's where the psychosocial and behavioral health issues are primary, and the effect on their health or their medical condition is secondary. Bereavement rounds. For any team that ever loses patients, these are really helpful ways to process some of the intense feelings and be able to move on to caring for the other children and families. Role plays. This has been an incredibly powerful move. I remember very poignantly many powerful role plays with pediatric residents who couldn't quite understand why families were so upset. But when they actually put themselves just for a moment in a pretend setting into the role of a parent who brings their child to an emergency room and doesn't take them home, the power of them to understand then what a parent might be facing was just amazing. Curbside consults, probably the most common way to do this sort of work. Direct consults with patients and then, with the other team members. Observations and modeling. So one of the things that happens when you help with medical procedures is that the other providers in the room, including the person who's doing the procedure, learn a lot about calming kids down and helping parents support their kids. Lectures and seminars is probably the one we fall back on the most, right? And probably not the most effective teaching tool. And then quality improvement activities. And I want to move on to this in particular. So what are some of the innovations? Well, new populations. There's new populations with co-located psychologists all the time. Multidisciplinary inpatient or intensive outpatient programs. A number of these are very famous around the country. Boston Children's, Pain Clinic, Mayo Clinic. Automatic behavioral health consults. This is a new innovation at Nationwide where everyone who gets admitted to the burn unit or to the intensive care unit gets a behavioral consult. Some QI activities, and this is something I'm going to mention more of. Medical providers at Children's National and endocrinology are doing screening for depression and all the diabetes adolescents. And then early exposure. One of the things I was struck by hearing from the National Medical Student Association this morning was something, when I was in oncology, we started a Big Brother, Big Sister program with medical students. Medical students were actually big brothers and big sisters to cancer patients. They also participated in our Day for Siblings. And unfortunately, even though it was incredibly well received and the medical students were wonderful and loved it for several years, it wasn't sustainable. Because when the medical student who really started it with us moved on to his residency, you really need a continuous sort of chain of champions, and it wasn't sustainable, which is really unfortunate. Okay, outcomes. I won't go through all of these, but basically it is possible to measure outcomes from this integrated training with chronically ill children and families. Everything from like the number of consults or referrals, changes in the length of hospital stay or usage of some medications, changes in language and communication about behavioral health across the different disciplines. All of these sorts of things could be measurable outcomes, and unfortunately, I think we haven't done a very good job yet at measuring the outcomes from training. But I want to mention briefly a quote from Dr. Maureen Monahan, who works with children with diabetes at Children's National. They were the team that instituted this mental health screening on the part of the medical providers. So qualitative interviews with these providers basically showed that they felt that it impacted the management of patients going forward. Just doing a mental health screening tool, which was a QI activity. The quote is that they feel that being trained to use a validated depression screener catches more patients at risk for mental health concerns than typical clinical discussion and offers the provider the opportunity to ask more probing follow-up questions. The providers became more comfortable with mental health discussions over the duration of the screening period. It's very powerful to think of a simple QI activity resulting in an improved management of behavioral health. Okay, and then lastly, sustainability. Certainly consult liaison services can be supported through patient billing, and consult liaison work can really expand into more behavioral health training across a hospital or a health system if funding were available. Co-location can be supported through medical specialty revenue and billing for behavioral health. Many of you probably know there is something called the health and behavior codes, which are CPT procedure codes that can be used when there is not a mental health diagnosis. So somebody with a chronic illness or a health condition across the lifespan can see a psychologist, and the provider can be reimbursed with a health and behavior code, not just psychologists. Grant funding, including for research, can augment salary support, and behavioral health research can actually be a driver for co-location and integrated training. And then lastly, training in behavioral health creates an appetite or an expectation for it in all of one's future positions. I think that's one of the things we hear from people who have graduates, and many of them go on to do integrated training. Thank you.